Hi, everyone. We are in the postprandial period. If I were not overly shy, I'd have you get up and take a stretch. So if you feel you want to do so, I, for one, will be pleased about that. But anytime you need to take a break, please do so. So I'm tasked, and I appreciate the opportunity, to talk about addressing workforce development needs and current gaps in the evidence with regard to palliative care. And just in case you didn't believe Chris, I truly have no disclosures. So I hope to cover a model of pediatric palliative care which I assume is familiar to everyone. I want to address the primary, as Chris noted, and subspecialty workforce needs. Start to think about current gaps in the evidence, which are vast, but I will particularly focus on this entity of suffering, talk about some opportunities, and really a call to action. So there are many different versions of this model, and essentially what this speaks to me is that for any child with a serious or life-threatening illness, throughout the course of that illness, we need to embrace an individualized blending of care directed at the underlying illness and at the physical, emotional, social, and spiritual, though we haven't heard a lot about spiritual needs. It's very, very important, of the child and family with continuous reevaluation and adjustment. This is a long-term commitment to our patients and families. Now, I put end-of-life care here as a separate box, albeit one in which you can sort of float back and forth, because all throughout this period of time, we are constantly living with, we, and in particular our patients and their families, are living with tremendous uncertainty. While we have the privilege of being able to say that children currently diagnosed with standard risk or high risk ALL have an over 80% chance of long-term disease-free survival, any parent who hears that statement hears, but they have a 20% chance of dying. And I, thank God, with my 3 children, don't think about a 20% chance of dying early for any of them when they get other engagements or illnesses. This is deeply felt by families, and it's the first thing that families hear when we disclose the diagnosis of cancer to them. So this approach to care begins from the moment we meet our families. Now, end-of-life care I think about as the time in which care is primarily focused on the comfort of the child and family. But we know that because of uncertainty, we find that children with advanced neuroblastoma who we send home with hospice support live for many months, if not years. We find that when we make a collective decision to discontinue a ventilator to allow that child to die naturally, they breathe on their own for longer than we expect. So sometimes when we're all engaged in a focus around comfort care, the child outlives his or her prognosis. And so there's a fluidity even to that period of time. And then bereavement care, needless to say, starts from that moment of diagnosis and lasts well beyond the lifespan of the child. And why we embrace this model, and I won't spend as much time on every other slide I show you, is because parents have told us through research that from the moment they hear the diagnosis of cancer, they hope for cure. They hope for life extension. They hope for a miracle down to the last breath of their child, but at the same time, hope for comfort and meaning. And so should we. So, what do we need to do to engage this model intensively in the care of all our children with cancer? Well, all interdisciplinary clinicians who care for children with cancer should have basic pediatric palliative care knowledge, skills, behaviors, and attitudes. Yet, an incredible study, albeit quite some time ago, led by Joanne Hilden and colleagues, found, and I'm not so sure it's that different, that as physicians, The most common way we learn this type of care is through trial and error, making mistakes and learning from our mistakes. And 71% of our training programs for pediatric oncology physicians lack a pediatric palliative care curriculum. And I'm not sure what the state of the board exam is yet, but I venture to guess that there are very, very few questions on this domain of care in our examination of emerging pediatric oncologists. Nursing literature suggests, again, a high need for PPC education at all levels, and there's very little known about where things stand for other disciplines. What about subspecialty, the subspecialty palliative care workforce needs? Well, as Chris mentioned, the field of palliative medicine, as we heard, has been a subspecialty for since 2006. The first exam was in 2008. And the field is there not to take over care, but to sort of lend that extra layer of support clinically when needed, and to move the field forward through asking important questions and then solving those questions. But only 58% of COG member institutions have access to pediatric palliative care programs. And thankfully, the number of pediatric palliative care programs are growing throughout the United States, and this was a study headed by Chris Feutner. But many, many of these programs are understaffed, and we heard about this sort of notion of a half of an FTE of a physician and a quarter of an FTE of a nurse practitioner and no social worker to embrace the needs not only of children with advanced cancer, but children with other serious illnesses as well. And yet families want access to palliative care. This was the study that was referred to earlier. Alicia Kassam at Sick Kids in Toronto headed a study of bereaved parents and found that only 3 of 15 elements, valued elements of palliative care, were often accessible to these families. And physicians agreed with what valued elements were, such as a direct admission policy. While there was agreement between physicians and parents, most of the time this element was not available, or an inpatient palliative care approach, or preparation for end-of-life care. And really importantly, another area that we haven't talked a lot about is sibling support and how needed that is, and yet access to intensive sibling support is not available. Well, what about a willingness to meet a palliative care team at diagnosis? And these are data hot off the press from Dina Levine, who did a 3-center study amongst newly diagnosed patients with cancer. And she actually enrolled 130 parent and child pairs and asked them about whether or not they'd like to meet a palliative care team at the time of diagnosis. And children endorsed that as yes, when they understood the definition of palliative care, as did parents. When they were told sort of the truth, that the palliative care team also provides care at end of life, they still remained okay, some uncertainty about meeting palliative care services, because the bottom line is that they care deeply about their well-being along the illness continuum. Well, there are the good news is there's increasing physician and, or clinician pediatric palliative care training and educational opportunities. There are actually 3 textbooks now of pediatric palliative care. And importantly, there are curricula that are aimed at training people on the front line. So we know LNEC, Pediatrics, is a long-standing nursing-focused curriculum. EPIC Pediatrics is an NIH-funded training program similar to EPIC for adults. That's a train-the-trainer model, and Stefan Friedrichsdorf has been leading the development of this curriculum, which is now complete. And the next training, in case anybody wants to know, is right before the ASFO conference coming up in May in sunny Phoenix. I think there's still some slots around. There's social work training programs as well, such as an end-of-life certificate program at Smith College. And then I was just asked earlier about fellowship training slots. It used to be that we can count the number of slots for physicians on one hand. Well, we're proud to say that there are over 25 slots available, but our graduates, if anyone's interested, are just getting snapped up because there are so many positions available. I was also saying earlier that I used to sort of invite someone to train with us and say, but I can't guarantee you a job in palliative medicine because there are no jobs out there. And now our graduates are being recruited all over the country. And we're fortunate to also be able to train annually a nurse practitioner and social work fellow, though many, many more of these interdisciplinary training slots are needed as well. And then there are increasing family education opportunities. I hope everybody picked up their copy of A Parent's Guide to Enhancing Quality of Life in Children with Cancer that was edited by Ruth Hoffman and Sandra Smith, and it has been sponsored by the American Childhood Cancer Organization. ACS has a commitment to has a commitment to supporting initiatives to enhance family understanding of palliative care. The Conversation Project initiative, together with the Institute for Healthcare Improvement, has a specific pediatric starter kit about having the conversation with your seriously ill child, and it's beautifully done and gently done. And one of the things that I've learned over the years is that what parent would naturally know how to begin this conversation with their child? I mean, it's not intuitive, but if you give them simple tools like listening for moments when a child might express some distress or asking the question, am I going to die? Equip them with a sense of not feeling paralyzed, but tell me more about why you're asking that. All those different tools can be taught and handed to families so that they don't live in fear of being asked that question. And I'll mention also Courageous Parents Network is an online forum now for parents with children with serious illness and connecting families. One of the biggest questions that we get clinically is, can I meet another family of a child with a similar illness to mine? And it's very, very hard to make those matches, but go online and you can find those matches yourself, and that's a great forum for families. And yet, emerging data also suggests that palliative care improves outcomes. Now, I have to confess, we don't yet have the Jennifer Temmel study in pediatric oncology saying that palliative care extends life, although I would hypothesize that it does, and you can understand why, because it enhances well-being and strength and resilience, and all that is needed in order to be able to have the reserve to undergo cancer treatment successfully. But we know that through sort of not randomized controlled trials, children who receive palliative care are more likely to have fun and to experience events that add meaning to life, according to bereaved parents. Families who receive palliative care in the context of oncology report improved communication outcomes, and children receiving palliative care experience, and these are data from our own shop, shorter hospitalizations and fewer emergency department visits. So we're starting to build the evidence base for palliative care outcomes. Speaking of the evidence, what are the gaps in the evidence? I'm paying very close attention to the time, by the way. There's very little systematic assessment of the gaps in pediatric palliative care, but there is one Canadian Delphi study, and you can see that the gaps center around the key domains of palliative care, which are what matters most for patients and parents receiving palliative care, what are the best practices in pain and symptom management, what are effective strategies in alleviating suffering, and what are the bereavement needs of families in palliative care. There's been a North American Delphi study headed by Justin Baker, and this study had a hard time coming to consensus. There were 20 PPC research priorities that were grouped into decision-making, care coordination, symptom management, and quality improvement. The needs, in other words, are vast. Let me just spend a few minutes talking about this framework for suffering that underlies some of our research. and it's sort of based, and Chris Feutner told me not to bring this up, but I can't help acknowledging the great work of Eric Cassell and his, the nature of suffering in his model, that suffering is individual and it occurs when the integrity of a person is disrupted no matter what the stimulus. And in pediatrics, we have family integrity. We have the patient, the siblings, the parents, the community. And we have threats to that integrity, which are the illness diagnosis, the symptoms, the emotional factors, and then invisible threats, visible threats and invisible threats, that disruption from normal life. And we will hear from Kirabona tomorrow about the disruptions and the financial distress that families endure, emotional factors, existential concerns again, and sociodemographic concerns. They act together to create an experience of intense suffering. And what we need to do as a community is think about genomics, for example, and targeted treatment interventions that target an individual's experience of suffering, and global interventions. We heard a beautiful overview from Jenny about how communication in and of itself and relationship building is an intervention, all to restore family integrity. So we heard a little bit about this early study of ours where we asked parents of children who died of cancer about the child's experience of symptoms and suffering in the last month of life. And we found that there was a high prevalence of symptoms and there was high suffering. This is a great deal or a lot of suffering as opposed to some, a little, or none from each of these symptoms. And you'll notice this theme of fatigue. I want you to pay attention to it. Emerges and pain emerges, shortness of breath, especially in the last month of life. But all these symptoms were experienced by children according to their parents. Well, what would the children say? So what is the most common response you get when you ask a child, how are you feeling? Good answer. But there's a lot behind the fine, right? I'm depressed, lonely, crying. We heard from Lori about that and how to try and elicit these experiences. Broken, I'm not just fine. So what we did was we have the parent data, and we wanted to understand the experience of children themselves in their own voices about symptoms and suffering. And we heard a little bit about, we used an electronics system to capture their responses, and those responses in a random half of kids were given to families and to providers to see if there would be improved outcomes. And unfortunately, from the voices of kids themselves, and these are kids with cancer that had advanced beyond initial treatment, we found the same spectrum of symptoms with pain and fatigue being most common, and when reported, being associated with high distress levels. And then in the subset of kids who actually responded to these surveys in the last 12 months of life, these frequencies, the prevalence of high suffering was even worse. So even in an era where we have a robust palliative care program, we're not doing a good enough job. These are data from Dina Levine's study at diagnosis, also showing a high spectrum of distress from symptoms. And then just to show you, by feeding back data, comparing our randomized group to control group, we saw a signal, although not necessarily powered to show significant outcomes across all subgroups, of improved quality of life domains, decreased sickness scores. And families want to participate in this kind of research. We asked them why they did so. To help others, because it was important for my child and for gift cards as well. I could go on, but I'm running out of time. I will show you that there are very few studies in palliative care, that these are the current number of funded NIH grants in pediatric palliative care. We can count them just under 2 hands. And yet we have emerging Networks of funding, both the National Palliative Care Research Center and the American Cancer Society, are providing startup funds for palliative care research for both career development and for exploratory grants. And that's really starting to sort of spread across the field. We are hopeful that Children's Oncology Group, recognizing the need through Lillian's great talk, will also incorporate some studies with regard to advanced illness. And we have an emerging volunteer, underfunded, but very, very dedicated group of investigators, the Pediatric Palliative Care Research Network, and I'm showing you our logo hot off the press, to promote this kind of research. And we've done 2 collaborative studies, a cohort study and the PediQuest randomized controlled trial, and we're going to keep going. So, we need to enhance pediatric palliative care training of interdisciplinary primary oncology workforce. We also need enhanced subspecialty PPC training opportunities. The evidence base is really low right now, but we need research funding to enhance it further so that we can continue to provide children and families with what they are asking for, including access to PPC, pediatric palliative care research opportunities, health, well-being, and quality of life. Let's make it happen. Thank you.